Yeah, good afternoon, everyone. Welcome to Light It Red podcast series, a joint initiative by Natco and Voice of Healthcare Team. Light It Red, a podcast platform dedicated to spreading awareness, sharing stories, and bringing hope to everyone impacted with blood cancer. Audience, you all know every year millions of people around the world are diagnosed with conditions like leukemia, lymphoma, and myeloma. Yet too often, signs and symptoms are ignored and go unnoticed. But today we have Dr. Neema Bhat, renowned hemato-oncologist and bone marrow transplant physician from Apollo Hospitals, Bangalore, to understand, explore what actually the blood cancer really means, and she will share her knowledge on diagnosis, treatment, as we explore how multidisciplinary care and clinical research is shaping in future of the blood cancer therapy. Welcome, ma'am. It's pleasure to have you here. It's always honor to welcome you on this Lighted Red platform, ma'am.
Thank you, Mr. Sundeep. Thanks to Natco and the platform for inviting me. And as you rightly said, blood cancer is something that is not really very talked about, but people are very anxious and apprehensive about it because I think the knowledge per se is lacking. So I think this is a very good platform and time and opportunity to discuss it. Thank you.
Thank you, ma'am. And coming to the basic part of this, ma'am, actually, what is blood cancer and how does it differ from the other types of cancer?
Right. So when we talk about blood cancer, mainly three types are there. We differentiate into leukemia, lymphoma, and myeloma. The reason we differentiate it is because each condition is found in people of different age group and different backgrounds. It's different from other cancers like stomach cancer or say breast cancer or esophageal cancer because whereas in blood cancers, since the blood circulates everywhere, we take it up by risk. So it is either high risk, intermediate risk, or low risk. And the signs and symptoms are very dramatic when it comes to blood cancers. Usually, they're more aggressive compared to solid tumors or other cancers. So very important for people to know about initial signs and symptoms, so it can be caught early and treatment can be started at the earliest.
Okay. And how many types of blood cancer actually, ma'am? What are the main types of blood cancer, ma'am? You talk about. Rahul, can you hear me?
Yes, I can.
Hello, Mr. Sandeep?
Yeah, I can hear, ma'am. Yeah.
Yeah. Okay. So you were asking how many types of blood cancers are there? So as I mentioned, mainly three types: leukemia, which is the most aggressive variety usually, and then lymphoma, which is usually cancer that involves lymph nodes. All of us have lymph nodes in the neck, in the armpits, in the abdomen. We call it groin or inguinal region, where the leg joins the stomach. Normal lymph nodes job is to make sure infection is limited to one part of the body, but when cancer affects these lymph nodes, it's called lymphoma. And the last variety is called myeloma, which affects mainly cells called plasma cells. So they produce certain proteins that help us prevent from major infections, and when cancer affects these plasma cells, it's called myeloma. So mainly we look at blood cancers as three varieties.
Ma'am, initially, while starting your talk, you are discussing about the risk. So generally, who are at risk, ma'am? If you consider the age or
Right. So that again depends on what type of blood cancer we are talking about. Leukemia is what we call it bimodal distribution. Actually, leukemia is seen in people of all age groups, starting from children. So we see leukemia even in children who are as young as 1 year or sometimes even less than 1 year, and we see it all the way till older people until the age of 70s, 80s, even early 90s. Lymphomas are more common in children who are above the age of 10, so teenagers and early adults, and usually people who are more than 50, 60 years of age. Whereas myeloma is mainly a blood cancer that is seen in older people. So we don't usually see it in people who are younger than 50. If seen, very rare. So rarely we see it in people who are in their 40s, but otherwise at least 50, 55 plus is when myeloma is seen. So risk factors, if you look at people and their lifestyle, now we are discovering that there is a lot of risk factors. Mainly obesity is linked, overweight and obesity is linked to a lot of cancers, including blood cancers. Lifestyle changes, so consuming a lot of processed food, consuming a lot of meats, indirectly is linked to blood cancers. There is no exact risk factor. Having a family member who has had blood cancer in the past increases your risk of blood cancer slightly.
Okay, ma'am. To understand the burden, ma'am, what are the trends you are observing in the incidence of this blood cancer, ma'am?
Yeah, so previously we did not see myeloma, as I mentioned. Usually, myeloma used to be cancer of the elderly, only seen in about 60, 65 plus. But now we are seeing that it's picked up in people as early as even in their 40s. In fact, the youngest myeloma patient I've treated was only 39 years of age. So it is a little shocking for us to see that, like, we see heart attack is occurring in earlier and earlier ages. Just like that, unfortunately, blood cancer also we're able to pick up in younger people. Uh, Previously, blood cancers in children was also not as common. We are seeing that age group also show more incidence of leukemias and lymphomas. Exact reason for that, as I mentioned, I think is lifestyle changes and high stress and all of these things that we are, sort of going through globally. But those are the changes we are seeing.
Okay. But when you talk about this leukemia, ma'am, this in children, so per population, any number is there, ma'am? Any incidence?
Uh, Thankfully, in children, it is rarer compared to adults. In children, it is rarer. So we are talking about maybe 1 to 4 range in about 1 lakh population. So it's not very common, but compared to
Mm.
before, we are picking up a lot more of it. I think because not just because the disease is becoming more frequent, but also because we know how to test for it. People know a little bit more compared to maybe 10, 15 years ago. What are the symptoms that, the child is not very active, get the child tested. So same in adults. I think people are a little bit more aware of seeking help a little sooner rather than waiting for weeks and months together. So it's helping us pick up more cases.
Okay, ma'am. Unlike solid tumors, ma'am, any other risk factors, for example, in lung, environmental exposure is one of the factor. Like any other factors are there? Any for
So
this?
yes, theoretically, exposure to a certain chemicals we say can put you at a higher risk for, especially leukemias. So benzene chemicals, because that changes the structure of our genes. So that kind of exposure, yes. There are some viral infections that can increase your risk for certain lymphomas. We call it EBV. Is one Epstein-Barr virus that increases your risk for certain lymphomas. Also, HIV. Patients with HIV are more at risk for leukemias and lymphomas. So these are environmental risk factors. But these are also not very strong. It's not as strong as, say, smoking with lung cancer. It's a little lesser than that.
when uh, when we talk about this diagnosis and screening, ma'am, so why is early detection is so crucial to blood cancer uh, to detect,
Yeah.
ma'am?
So especially when we mentioned about, leukemia, as I said, it is very, very aggressive. So just to give you an example, this happened very recently. So yesterday I saw, a very young patient. She is in her 20s. Her only symptom is she's had some tiredness, some fatigue, reduced appetite, little bit of fever here and there. She's not feeling, very good. That's it. That was her overall symptom. And blood count has been done about 2 weeks ago, where her hemoglobin is low. It's around 7. WBC count was around 9,000, and platelets were around 80,000. So everything marginally low, not very low. But I repeated her blood counts yesterday, and there is a drastic change. Her hemoglobin has fallen from 7 to 5. WBC count has increased, it's doubled from 9,000 to 18,000, and platelet counts have further fallen. She has developed a large spleen, she has lymph nodes. So, all these changes have occurred in a period of about a month, less than a month. And her symptoms were very faint. And soon enough, we did a peripheral smear and we diagnosed her with leukemia. So, especially leukemia, acute leukemias, the diseases that fall in that category, can be quite aggressive. So, unless we pick it up soon, your platelet counts can drop, hemoglobin will drop, you might get an infection. So, they're quite aggressive. Similarly, with lymphoma, some types of lymphomas are quite aggressive. We call it non Hodgkin's lymphoma. Those can be very aggressive compared to other types. So it is best when you have a doubt, you make sure to get it checked out at the earliest. Don't ignore it. Now, some people ignore their symptoms for weeks together and they come very sick, either with a very bad infection. Sometimes myeloma patients will come with kidney failure because kidneys are already damaged or heart is affected. So all of those things, to avoid, the best thing is to make sure that it is caught early. So you're very aware of your symptoms, so we test it and catch it early.
So it's right, ma'am. It's an alarming situation then. So every sign and symptom should not be unnoticed. That is what.
Yeah, if something is not getting better, say within about a week's time, and it's only you feel that it's getting worse, then better to get it addressed. At least you ensure nothing is there, then you are peaceful. But if something is there, then that is the mentality that I have seen also. If we say, okay, ಈ test ಮಾಡಬೇಕು, the patient will be like, no, 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 why do you want to get this test done? What if we pick something up? So my answer is, if we pick something up, that's precisely the reason why we are testing, isn't it?
Yes.
So that fear mentality is something I think we should sort of get out of, and we should start thinking we should diagnose it early and treat it early, not say, oh, what if it's this, let me not test only. That attitude is something that should change.
Okay. But anyways, connecting to this question, ma'am, how common it is the patients are getting delayed diagnosis, ma'am? Because they also, how common it is?
So it is still fairly common. I think better than what it was 5 years ago. But we still see myeloma patients who come in kidney failure. The only symptom they've had is they've been tired and they've had some achy, bony pains. Usually these are patients who are in their 60s, 70s. They don't want to go to the hospital. They think it's just age related. I'm 65 years old now, so feeling tired is normal. So that sort of makes them push coming for follow-up or coming to get medical opinion. So we still see, especially myeloma patients. Rarely we see even pediatric leukemia patients come little later in their presentation, because it's difficult for them to verbalize their symptoms. Pediatric patients, they don't really tell, okay, now I'm feeling tired, I'm not able to eat, or I have a fever. So for parents to pick that up and bring it to the doctor's notice, there may be a little delay. So it is still very common that we get patients who are slightly advanced. And awareness, I think, is the only thing that can change all of this.
Yes, awareness. So that is what we are also trying to do, ma'am. So
Absolutely.
and connect. Thank you, ma'am. This screening recommendations, unlike other cancers, is there any other type of recommendations, ma'am, for blood cancers?
Specifically for blood cancer, there is no one screening test. Like for breast cancer, you have mammogram. So like that, for blood cancer, we just say routinely get one complete blood count. So, list of all your blood counts and peripheral smear. So somebody should look at the blood under the microscope. That is a very general test. Apart from that, there is no one screening test that's, recommended for all. There is no need for you to undergo a CT, ultrasound, all of that on a routine basis. But general health check, visiting a doctor at least once a year and making sure to get a blood count done. I think these are very simple things that can be done easily and can catch things very early.
And ma'am, is there any family history, just like other cancers? If the person has already diagnosed with the cancer, in the same family, it can be just like heredity or something like that.
Very fortunately, it is no. It is so. If somebody has blood cancer, automatically it does not increase your risk. So that is one reassuring part. But there are a few gene mutations. So, say if more than two people have been diagnosed with similar cancer and genetic testing has been done, there are some genes that can definitely put you at a risk for blood cancers. So, if such a gene has been picked up in the patient, then we usually say, get tested more frequently, undergo that particular gene test. So if it is positive for you, you have to be monitored more regularly or more frequently. But otherwise, somebody having myeloma, somebody having lymphoma does not automatically increase family members' risk.
Okay. And coming to the part of this treatment and innovations, ma'am, how has the treatment landscape been evolved in the blood cancer, ma'am, in the last 5 years or 10 years or last decade?
So I know I'm a hematologist, I'm a hemato-oncologist. So I would say, I think hematology is one of the fastest evolving fields I have seen, oncology and hematology. So the reason I say that is, I think the first CAR T therapy that was done was approximately about 8 or 9 years ago, not too long ago before that. So now CAR T cell therapy has become important part of any blood cancers protocol. So whether you take leukemia, lymphoma, or myeloma, there is always option for treating, with CAR T in the second line of treatment itself. And I think it is one of the fastest treatments that has come into recommendations list in a very short period of time. And when you asked about innovations, we only had chemotherapy before this for blood cancers. Not much else was available. Chemotherapy and bone marrow transplant. But now we have all these antibodies. We call them targeted therapy, immunotherapy. So basically, these medicines that can go find the cancer cells which have certain markers and kill only those without causing, major side effects on other organs. I think that's a really big blessing, because as much as it is important to treat the cancer, it's also important to preserve the individual. We don't want to hurt all their organs and treat only the cancer. We want the cancer to go, but the person to stay intact as much as possible. So I think that way, immunotherapy and targeted therapy, and specifically CAR T cell therapy, I think have made a huge difference in the treatment of all these blood cancers.
You are saying CAR T cell has becoming a promising therapy in treating blood cancer patients. Can you
Yes.
can you throw a little light on this to understand
Yeah, so
what
first of
actually
all, we need to understand what is CAR T cell therapy. I describe it very simply. It is like having an army within your body to fight the cancer. We all have regulatory cells, okay? They're called T cells or T lymphocytes. They're part of our immune system. But these cancers, they're very smart. These cancer cells, they are so smart that they evade or they hide from our immune system. So what we do with CAR T cell therapy is we take these lymphocytes or T lymphocytes from the patient, we sensitize them or we sort of wake them up to say, okay, hey, this is the cancer. You need to go find it and kill it and fight the cancer. So that is what we do. We collect the lymphocytes, we take it in the lab, process it, modify it, and give it back to the patient. So once these T cells wake up, they know that, okay, leukemia is there over here, I need to go fight it. Lymphoma is there over here, I need to go fight it. Same thing for myeloma. Myeloma is not yet used very rapidly in India, but now it is catching up. By next year, we'll have a myeloma CAR T available quite easily. So I think, as I said, it's your own RV. Giving medicines from outside is one thing, but waking up your own body to recognize these cells and fight it is a very important part of treatment for blood cancers.
understood? So you have your own system is letting you to fight, as you said, army
Yes,
is
yes.
inside.
You're sort of waking up your own system to fight the cancer. Just like you fight infection, yeah, you're waking up your system to fight the cancer.
And how about this targeted therapy is getting evolved on this?
So targeted therapy or immunotherapy are, as I said, every cancer cell has a particular marker. Okay, so we are making medicines now. We call it monoclonal antibodies. So those medicines specifically identify the cancer cells with that target. And how it helps is, say you have 100 cells, in that only 2 or 3 are cancer cells. Okay, but when we give chemotherapy, the chemotherapy is going to kill all the 100 cells. When we give targeted therapy, it is going to go and kill those cancer cells alone. There may be a little bit of side effect on the normal cells, but it won't destroy the normal cells. So we can't give full dose chemotherapy for patients, say, who have liver problems, kidney problems, heart problems. But those patients can still tolerate targeted therapy because it is not damaging the other organs. So we're still able to treat the cancer without causing any major organ damage. So that is, again, almost every month there is a new drug. For myeloma there are new drugs, for lymphoma there are new drugs, for leukemia. These are all called targeted therapy because they target that particular marker on the cancer cell, and they're able to kill that cancer cell. There is a small downside to it. All these medicines are still a little expensive because most of these trials have been done in the West, and some of these medicines we're still importing. But as time goes on, as Indian doctors are also starting to use it, the cost has started to come down slowly. For example, I know when daratumumab is an important medicine that has been in use in the West for more than 3-4 years now. But in India, doctors have started using it only over the last 1.5 years. Cost of this daratumumab was almost around 2 lakhs. Now it has come down to less than 1 lakh. And that will only get better as more and more doctors use it. More and more patients are open to taking it. Then the cost will automatically come down. But it is the intent to try to kill the cancer with the right agent that's important.
And one more thing, ma'am, just wanted to know that bone marrow transplantation. When does you recommend patients for this therapy, ma'am?
Great. So bone marrow transplantation for blood cancers is a 1 hour topic, by itself. So when any cancer is not being treated with, say, chemotherapy or targeted therapy, then we sort of have to do a system reset, right? Bone marrow is nothing but the factory or the system that is making your blood cells. When the system is so badly affected that no medicine is working, then we have to reset the entire factory or to reset the entire system. That's when we do bone marrow transplantation. So we have to take a healthy donor, someone who doesn't have that particular medical condition, take their bone marrow and then treat the patient who has this disease and give that bone marrow to the patient so that their entire system sort of undergoes a rewiring or resetting and they start making fresh new cells and the cancer is gone. So usually bone marrow transplantation is recommended for relapsed or refractory. So if it's not responding to the initial chemotherapy or targeted therapy, that's when we recommend bone marrow transplant.
Okay.
Only
So many.
exception is in myeloma. Myeloma is a condition where any fit patient who has myeloma, we recommend they have to undergo autologous transplant because in myeloma, you don't have to bring other person's cells. We preserve our own cells, give high dose chemotherapy to kill the myeloma, and then give those stem cells back. So it's our own system reset with our own cells that has been harvested. We treat the body and give it back. So only myeloma and some varieties of lymphoma is where we say even if the treatment is, body is responding, even if the disease is responding to the treatment, you still do an autologous stem cell transplant to give the best chance of cure.
So many options are available to treat blood cancer, but one thing is that how does you personalize the treatment for different blood cancer and different types or stages? How does you
Right.
personalize it?
That's an excellent question. So right from the patient time the patient walks in, we're always thinking, okay, this is the type, this is the risk. So we look at a lot of factors, not just what type of blood cancer is it, how well is the patient preserved, do they have normal organ functions, is their heart okay, is their kidney okay, is their liver okay, can I give this medicine? Say for some patients who can't tolerate chemotherapy because they already have a really bad kidney, I may choose to give them targeted therapy. If a patient is really frail, I may have two people both around 50, 60 years of age, but one person has really bad kidneys or really bad lungs. I can't do transplant even if they have myeloma. So we change we sort of fine tune it based on how the
Mhm.
patient is, what is their condition, what is their risk. Like low risk patient, they don't need a bone marrow transplant, they don't need high end targeted therapy, we can give them mild chemotherapy and control their disease. So it goes based on a lot of factors. What is the experience over last few decades of medical research and what all has been studied in hundreds and thousands of patients. Only based on that we take a call. Of course, also on how the patient can tolerate it.
One question always triggers the Indian mentality, ma'am, that is affordability and accessibility. Even though the treatment has evolved, these many options are still there. But how
Hmm.
often these treatments are affordable and accessible to the patient?
Hmm. So that's a very good question. So the reason we think about affordability, it's always a question, right? We have to make 1 second. The reason we think about affordability is when okay, so blood cancers, it is not just chemotherapy or targeted therapy. It involves us giving a lot of blood products, a lot of antibiotics, especially in leukemia patients. Say it is, young person, 20, 25-year-old who's diagnosed with leukemia. I have to give them chemotherapy, which causes their blood products, blood counts to go down. So I have to give them blood, I have to give them platelets, they develop fevers, I have to give antibiotics. Usually more than chemotherapy, it is a supportive care, which is equally important. If I just give chemotherapy and the patient is suffering from infection or low platelets, it is not going to help the outcome. So cost wise, yes, compared to other cancers, treatment of especially leukemias is a little more expensive because it requires prolonged admission and very sort of tight monitoring and care of the patient. Um, but lymphoma and myeloma, now we are moving towards almost treating them on a daycare basis. So hardly any admission is required. Doses have been changed, protocols have been changed so that patient can come, take the treatment at daycare and go. So as I also mentioned, as more and more people start using slightly higher end medications, the cost will automatically come down. And I think the recent government has also been quite helpful. They have brought down GST to try to help out people. We are only trending towards a point where cost will significantly reduce even further.
And coming to the psychological impact, ma'am, because cancer itself, the word itself, so how does you give the emotional support or psychological support to the patient when he's diagnosed with the cancer? Because cancer is not only affecting the individual, but it also affects the entire family members. So how does you tackle, ma'am?
Absolutely.
Because
Yeah.
yeah,
So best way is, again, it depends on, is the patient young or old. So if the patient is young, I try to educate them themselves and tell them this is something that has hope. This is something that can be treated. Don't completely lose hope, because the moment you break the diagnosis, for them it is like the end of the world. They're immediately like, my, especially young people, my appearance is going to change, my life is going to change, my career is not going to be there. So a big part of, I think, emotional balancing or psychological support is reassurance, because we know how treatable these things are. We know how treatable, even most blood cancers are. We have to start telling them and giving them hope. Let us start the treatment. You will respond to it. There is definitely hope for cure. So the stronger you give the hope to the patient, I think that is half the psychological support you can give. Apart from that, we have counselors. We have they're called psycho-oncologists. So they basically spend time with the patient and their family, try to see how best they can help them lead their life. Like if you have IT people, or if you have most people who are able to do desk jobs, we give them letters so that they can work from home or try to still keep in touch with their career, because it's very difficult to deal with a very bad diagnosis. And if you're feeling okay, not have any job to do, then that thought will ruminate and make you more and more depressed. So we try to keep them connected to their real life as much as possible, and at the same time be reassuring and give them hope and say, this is curable. You just have to have a strong mindset. um, when it is elderly people, we counsel the family and give them a realistic idea. If they're very elderly, then we may say strongly, don't push the patient too much. Let them rest, and at the same time continue treatment as much as possible. But most elderly patients sort of prefer to know, and they are okay to continue treatment, but they have realistic expectations, thinking, okay, however long I'm able to do all my activities, I want it to happen. I don't want to be hospitalized. If they have that mindset, we support it. We respect their wishes and say, we'll not push. We'll give you only as much as you can tolerate, and support them in all other areas as much as possible. But as I mentioned, I think just like other fields, counselors play a huge role. They talk to the patient and the family, sometimes parents of the children who are diagnosed, and help them sail through the journey as best as possible.
my next question was that only, ma'am. Caregivers or counselors, how they tackle, and even though these many therapies are available, this much targeted, whatever you have explained to us in this platform, ma'am, but still there is a stigma or any misinformation surrounding this blood cancer topic now. Still,
Yeah. So as I said, just to give an example, if I go into a social gathering, not as a doctor, okay, I'm not going to a conference, I'm just going to a family function, and people are like, what kind of specialist you are? And I tell them I'm a blood cancer specialist. So immediately you should see the expression, on their face change. People just stop talking and they're like, oh my god, most of your patients must be dying. That is still the thought that is there in the society. And I should say, thanks to people like you, you're trying to make the effort to bring out this point that blood cancers are treatable, and not all blood cancers are same. I think from old movies, we know that blood cancer patients, they suddenly start vomiting blood and they faint and they die. So it is not that dramatic, or it's not that harsh anymore. But of course, you put the right tools to testing, you pick up the patient at the right time, and you treat them with the right means. In children, about 90% of the blood cancers are actually treatable. In adults, it depends. Chronic blood cancers are very controllable. They may have to take a tablet, or may take a small injection. But chronic blood cancers, usually the response rate is as good as 80% plus. So most of them with chronic blood cancers, we call it chronic leukemias, do very well. Okay. The acute leukemias in slightly older people, yes, it is, outcomes are maybe about 50 to 70%. So that is something that requires improvement. It requires more focus, more research. But there is no longer the thought that blood cancer is a death sentence. Definitely no. There is treatment available for every type of blood cancer, not only just upfront but also relapsed blood cancers. If you to talk about myeloma, we sort of consider it like a chronic condition. Like, if first line therapy fails, then second line is there, second line fails, third line is there. So there are about 8, 9 lines of treatment available for myeloma. It is just a matter of changing the line of treatment and continuing the medicines. Some of them are tablets with a small injection here or there. So it is best to not make the decision or call it your own death sentence. Go meet the right specialist. Try to meet a hematologist or hemato-oncologist and discuss all the options available before you decide, okay, this is not treatable. That stigma has to be removed.
Nice, ma'am. Thank you very much. And still, ma'am, I often get what when the patients talk to you. Often, when patients talk to you, what kind of common myth you have gone through this in this
Yeah.
common
So
myth?
first, I told you, most common myth is you tell them they have blood cancer, they think they're going to die within the next 1 week or 2 weeks. That is
Okay, we
number
understand.
one.
That is very
Second thing, they think if one person in the family has blood cancer, it's going to come to them. They almost think like it's a communicable disease that, oh, this person has it. Is it okay for them to play with the other children in the house? Is it okay for them to, say, cook food? Or is it okay to wash utensils? Are they going to spread it to us? They treat it like an infection, which is wrong. So cancer is not an infection. It doesn't spread by sharing the same plate or sharing the same spoon, or cooking food. So that is not the case. Another myth is, especially for myeloma patients, because they think the moment we start treatment for especially myeloma, they think we're going to lose all hair, I'm going to become like, typical cancer patient, lot of mouth ulcers. So as I said, with more and more targeted therapy available, the appearance of cancer patients also is changing. When we give only myeloma treatment, most patients look not like patients, they look normal. So no hair loss, no mouth ulcers, they eat very well, they have a good quality of life. So automatically treating blood cancer as my life is completely going to change, I think that is a big myth. Another thing is certain food products. And I've heard people come and say, eating this particular thing is what gave me cancer. I've been taking BP medicines for about 10 years. That is what gave me blood cancer. I've been taking sugar medicines for about 5, 6 years now. I told my doctor I don't want any medicine, but they still gave it to me. So I've ended up with cancer. That is another common myth. So I think those are all things that people should get out of. Medicines don't give you cancer. It is mostly lifestyle and a lot of other factors that are not really in our control.
one last and powerful message for our audience, ma'am, through this platform.
Don't lose hope. I think that is the biggest message I would want to give. As a hemato-oncologist, please don't lose hope that blood cancer is not a death sentence. You end up diagnosing at the right time, start treatment at the right time. It is a very treatable disorder. Yes, it is a long journey, but it's a fruitful journey most of the time. You place with the right doctor, it's a very fruitful journey. Start with a negative mindset, with negative hope. Start positively thinking, I will fight this and I will overcome this. And it is very much possible to do so.
Thank you, ma'am. Thanks for highlighting the key understandings of the blood cancer, and you have explained what is actually the blood cancer. You have gone through this signs and symptoms, treatment evaluation, everything you have touched, ma'am, for our audience. And also, one thing, ma'am, you are very patiently explaining each and everything. You have given the examples also, and you have given that confidence for this blood cancer patients or who are listening to this. So blood cancer is treatable when it is detected early or it's manageable. Good. Thank you, ma'am.
Yes.
Thanks for your valuable time.
Thank you very much, Sandeep. Yes. Thanks a
Thank you,
lot.
ma'am.
And keep up
Thank
the
you.
good work. Yes. Thank you.
Thank you, ma'am. Thank you, ma'am. Ma'am,